my last slide is, echo is still the workhorse for the initial diagnosis and management of these patients. CMR reduces the unexplained DCM category with providing function, ischemia, and tissue properties. In my practice, we are using CMR more and more to determine who gets an ICD or doesn't get an ICD and for prognosis. But remember, it's expensive and needs training. Thank you. Happy to take questions.
Can I ask you a question, Chandra?
Sure.
Could you tell us what kind of a prosthetic valve patients can undergo CMR and those who cannot?
So everybody with prosthetic valve can undergo CMR. So there isn't really a restriction for that. Ron, do you have an opinion?
No issues. All prosthetic valves can undergo testing. Even many pacemakers, ICDs, it still depends. But yeah, valves are not an issue.
Any other thoughts? Vera, how do you use echo in your practice for cardiomyopathies or triaging them, prognosticating them?
Well, as you point out, the echo is the first test that's often done in patients with symptoms of heart failure. And it's great because it can first separate out if it's a reduced ejection fraction problem, a normal ejection fraction problem, or a medium ejection fraction problem. And the differential diagnosis for the cause of the heart failure is varied according to how severe the LV dysfunction is. Our practice, in addition to doing a full echocardiogram with the assessment of LV and RV function and valvular function, we do strain imaging on all these patients as well, since that may also provide a clue as to the etiology of the heart failure, and also may have some prognostic information, because if the strain is severely abnormal, that may suggest more fibrosis and worse prognosis. And sometimes we can be very surprised, and I'll give an example. In patients that undergo TAVR for low flow, low gradient aortic stenosis, we find there are a subset of patients that never really improve. And on strain imaging, we have found that there's actually a higher incidence of amyloid, of senile amyloid or TTR amyloid in this population, which makes sense that since this population tends to be more elderly. So that may provide an explanation as to why some of those patients don't improve after they undergo their TAVR. So the important thing is to do a comprehensive echo, including strain imaging, in these heart failure patients, that can help guide what the next testing may be, and also the treatment and prognosis of that individual.
Ron, how do you use it in your practice? Do you get it on all your dilated cardiomyopathy patients?
Yeah, so I think for us, the first branching logic is this ischemic or non-ischemic, and if we think the likelihood of this of ischemic is low, and this is more likely to be a non-ischemic, we may go straight to an MRI. We may do a stress MRI as well, or if we've ruled out coronary disease was a coronary CTA, or ruled out ischemia was a stress test, and we've established it's non-ischemic. In the majority of the non-ischemics, we will do MRI, and I really like the slide you show with all the different patterns, because ultimately there really are unique signatures of different pathologies that can inform you both about the disease but also about the prognosis. And also for some of these patients with LV dysfunction, if we're on the fence about their risk and do they need a defibrillator, the amount, it's exactly as you've shown, both the location and the amount of fibrosis can be very helpful at identifying future risk.
Okay, so some audience questions. What about CMR in pacemakers? Ron, you want to mention something about that?
Yeah, so pacemakers, most of them are actually okay. There are pacemakers that are kind of approved and been tested and are known to be safe, and for those there's no issues. And then there's devices that we call them legacy devices that they haven't been formally tested, but there's now multiple large studies looking at the safety signal, showing that actually it's safe to do these patients. In some patients with pacemakers or defibrillators, there could be artifacts, more so in the right ventricle. So if you're looking for right ventricular pathology, like ARVC, that might be an issue sometimes. But for the most part, most pacemakers are okay. You're going to often have to interrogate the device before and after. And then even for ICD, some of the ICDs now are compatible for MRI, but not all.
So there were a couple of audience questions. One was, is echo better for Fabry's or MR? Certainly MR is coming out to show very distinctive features. One of the things that can happen is a very low T1 value. It's in a patient who looks like hypertrophic cardiomyopathy. Then there was one question, is 2D strain always reproducible? I'll let you answer that, Vera, in your next talk. Are there particular patterns of scarring in HCM that can allow you diagnosis? No, there isn't any particular pattern. Sometimes you get at the insertion of the RV some scarring. And Ron, I think we'll take one more question for you. Role of CMR in a patient with myocarditis in the COVID era.
Yeah, I think it's a tough one. Most of the patients, if you have elevated cardiac enzymes, you've ruled out coronary disease, you can clinically say the patient has myocarditis. And the question is adding MRI helpful diagnostically? And probably in most cases, I would say no. Now, if there's LV dysfunction, then you have to maybe at that case, you'll say, well, how much fibrosis? So if there's LV dysfunction in a pattern that suggests stress-induced cardiomyopathy like apical ballooning, maybe follow that patient, the EF gets better, you can just say this is stress-mediated, you're done. But if there's LV dysfunction in a different pattern, very high enzymes, I think MRI is helpful if you're not sure, was this really an infarct or myocarditis? This is where MRI is most helpful. Obviously, if the patients have a lot of arrhythmias, then you're concerned about scar and location of scar. Perhaps MRI will be helpful there. But I don't think every patient needs an MRI because we simply, as much as the images are nice, we don't always know what to do with them clinically.
Right. And that is the great message. Not only in the COVID era, in general, every patient does not need an MRI. You have to have a clinical question that needs answering. Only then you go to an MRI. Okay, I think we are back on
every imaging study, right? Any imaging study, if there's not a really good compelling reason and you're not going to know what to do with the answer, then don't order the test.
Correct, absolutely. I think we are back on the time schedule, so Vera, we'll go over to you and tell us where advanced imaging is going, and you start with strain, and then Nat will go into 3D echo.
So with your permission, what I'd like to do, I have a case that I'm going to present with strain, and I ask that the panel actually stay engaged because I have some clinical questions that I'm going to be asking during the presentation that I'd like the panel to answer as we go along. Would that be okay?
Happy.
Okay. Are you able to see my screen?
Yeah.
Yes. Okay. So with the most common use for strain these days is in cardio-oncology. So I'd like to share a case of cardio-oncology with you to demonstrate how we can use strain in the clinical setting. So just to remind you what strain imaging is, strain is the percent change in length of the myocardium during relaxation and contraction. And this image here is of a piece of myocardium that's contracting and expanding. And as you notice, this is looking at a longitudinal fiber. So when the heart is contracting, you see that the fibers are shortening. And then when the myocardium is relaxing, the fibers are expanding. So this is why longitudinal strain of the left ventricle is a negative value at peak systole. And the strain is the change in length between when it's the longest versus when it's the shortest, and it's the percent change of that. So we can measure strain in the longitudinal, circumferential, and radial aspects. The most commonly used strain value for the left ventricle is the longitudinal strain. That is shown here. And by echo, we measure strain using a technique called speckle tracking. And basically what that is software that follows the little speckles from one location to another throughout the cardiac cycle on our echo image. So here, if we see these little dots and where they are in end systole versus where they are in end diastole, that we assume then is a marker for the change in length of the myocardium, and that's what we use to measure strain. The nice thing here is it's not affected by beam angle as we have with Doppler imaging, and this results in less inter and intra-observer variation. Do keep in mind, however, that it is not completely independent of preload and afterload. So knowing what your blood pressure is and what the filling pressures are may make a difference in the strain value. For the function of cardio-oncology, I do bring your attention to this guidelines document that was published by the American Society of Echo in 2014, and it's an expert consensus for multimodality imaging in evaluation of adult patients during and after cancer therapy. So much of what I'm going to discuss with you comes from this document, and if you are looking for guidance on how to manage your cancer patients using echo and strain imaging, I do suggest that you review this article. So just a couple of definitions. We have the concept of cancer therapeutics related cardiac dysfunction, and basically that's dysfunction of the left ventricle that's caused by the cancer therapy. And the CTRCD is defined as a decrease in the LV ejection fraction of greater than 10% to a value less than 53%. So important to keep that definition in mind. If it's within 5 percentage points of baseline, usually those abnormalities are reversible. If it's a greater than 10% change from the nadir but remaining more than 5 percent points below the baseline, that's partially reversible, and irreversible is improved by less than 10 percentage point of the nadir and remaining 5 percentage points below the baseline. So just some information for prognostic purposes. We also divide LV dysfunction from chemotherapy into 2 types. The type 1 is, the prototype of this is anthracycline-induced cardiac injury. This is a dose-related phenomenon. It is often irreversible. And early treatment with heart failure therapy can prevent further LV remodeling and EF decline. So detecting this early has important therapeutic and prognostic implications. Type 2 dysfunction is a non-anthracycline agent phenomenon. Trastuzumab, used for breast cancer, is a prototype for an agent that causes type 2 dysfunction. This is not dose-related, is often reversible, and has no apparent ultrastructural abnormalities, which is why it's often reversible. So let's go on to our case. Here we have a 52-year-old female who has right-sided metastatic breast cancer. She has a history of chemotherapy-induced cardiomyopathy since she was treated for 4 cycles of adriamycin and Cytoxan. She's HER2 positive with her breast cancer, so following the adriamycin and Cytoxan, she started treatment with trastuzumab. So here is her baseline echo. This is before starting therapy with the trastuzumab. She has an ejection fraction of 50%. So has a mild cardiomyopathy related to the anthracyclines that she received prior to the trastuzumab. Here's her two-chamber view. So you see that her ejection fraction is mildly depressed in a global fashion. Here's our three-chamber view. And here's her global longitudinal strain, which is at a relatively normal range of minus 18.3%. So she starts her trastuzumab. 6 months later, her ejection fraction is slightly lower at 45%. Here's her two-chamber view, three-chamber view. And now her strain is lower at minus 12.3%. So now we have a woman who is receiving trastuzumab. Her ejection fraction has declined from 50 to 45%, and her global longitudinal strain has declined from 18 to 12.3%. So my question for the panel is now, what would you do based on this information? Would you stop the trastuzumab? Would you begin heart failure therapy? Would you stop trastuzumab and begin heart failure therapy? So choice 2 would be continue the trastuzumab and continue with heart failure therapy, or initiate heart failure therapy. Number 3 is stop the trastuzumab and begin heart failure therapy. And number 4 would be just continue as you are, continue with the trastuzumab without adding any heart failure therapies. So I've asked the panel for your opinion.
Number 3.
Number 3, stop trastuzumab and begin heart failure meds. Okay, anybody else?
Number 2,
Number
heart
2,
failure. Begin heart failure meds.
begin heart failure meds and continue the trastuzumab.
Correct.
Ron,
And
do you have?
follow, closer follow-up.
Okay. All right, so what we did here is we continued the trastuzumab and added heart failure therapies. The rationale being that the drop in ejection fraction was quite small, and perhaps even within the limits of measurement variability. We do not yet have data on what to do with a preserved ejection fraction and a drop in strain. We know that a drop in strain is predictive of future drops in ejection fraction, but we don't have data yet of what to do with therapies if the change in the strain imaging without a subsequent change in ejection fraction occurs. So given that information, we continued the trastuzumab, but went ahead and initiated the heart failure medications as shown in the slide. Oops. Hold on here. All right, so several months later, she is feeling increased fatigue, palpitations, and shortness of breath. And her ejection fraction now is quite depressed. She's had some follow-up in between. This is a 15-month follow-up, but she was having echoes every 3 months, showing stability of the strain and of the ejection fraction. And she has metastatic disease, which is why the trastuzumab is being continued for more than a year. So here at 15 months, now she has a severely depressed ejection fraction at 34%. And you can see visibly that it is visibly depressed. And here's her strain now at minus 11.9%. So now what would we do? Same choices as last time.
Number 3.
Number
Thank
3.
you, Ned. Finally, you
There is
one
none. Pardon?
Okay, so in fact, in this case, the trastuzumab was held and her heart failure medicines were further titrated. She had repeat echoes on a monthly basis. And then 1 month after escalation of her heart failure medications and stopping the trastuzumab, Her ejection fraction improves to 40%. And her GLS improves slightly as well to minus 14%. So now what do we do? Tough, I know. I'm not going to present you something easy.
Yeah. Any other, what's the next best combination chemotherapy agents?
So that's one option, is to remember so the trastuzumab is still on hold at this point in time. So our options here are to recommend that the trastuzumab be restarted, because we know that sometimes even despite a drop in ejection fraction, a drop in strain, if we can get the function back up on good heart failure therapies, sometimes restarting the trastuzumab, actually the patient will do okay. Or alternatively, we can say, you know what, not worth the risk, and then start looking for alternative therapies.
Did she get anthracycline or just trastuzumab?
She had anthracyclines before the trastuzumab. So her initial therapy was adriamycin and Cytoxan, and that's why her initial ejection fraction was 50%. So she did not start out with a normal LV. And it was as a result of the anthracyclines. And I think your point is well taken, because individuals who have anthracyclines are at higher risk of having trastuzumab-induced cardiotoxicity. It's worse in the early studies when they actually gave they were looking at whether or not to give the trastuzumab at the same time as the anthracyclines or following the anthracyclines. And the individuals who had anthracyclines and trastuzumabs given at the same time had the highest risk of toxicity. So nowadays, they are not given at the same time, they're given in sequence. But you are correct, her anthracycline therapy did cause some dysfunction before the trastuzumab was even given.
Right. The reason I asked is the anthracycline toxicity is thought to be less reversible than the trastuzumab, right?
Correct.
So what did you do next?
So what we did is we continued to hold the trastuzumab and tried alternative therapies. So she was tried on various therapies and then treated with another drug called pertuzumab, which is a drug that's often used in combination with trastuzumab. In this case, because of the persistence of her LV dysfunction and the drop in strain, it was felt that adding the trastuzumab back would be too much risk. And there is a possibility with pertuzumab of some LV dysfunction as well. So she was followed very carefully with sequential echoes with strain imaging while on pertuzumab therapy, as well as the highest dose possible of her heart failure medications, and was noted to have a stable ejection fraction and strain while continuing the pertuzumab. And here is her echo after 3 years. Her ejection fraction is 40%. Here's the 2-chamber view, the 3-chamber view, and here's her GLS at minus 15.6%. So certainly not perfect, but we were able to get her up from that 34% and minus 11% strain and maintain this while maintaining her chemotherapy. And we have to keep in mind here that, she has metastatic disease. So if therapy is stopped, she's going to die. So oftentimes it's a balance of trying to do your best with maintaining LV function, yet providing the chemotherapy that's going to keep the individual alive. So by doing really close serial examinations and following both with strain and the LV, sometimes these decisions can be very difficult, but nevertheless, trying to do the best you can to balance LV function and treatment of the underlying cancer. So she's still
Just a
doing
question,
well.
Veena.
I'm
Question.
sorry?
I have a question.
Yes.
Do you think the strain imaging did really impact, because you're following LV ejection fraction? Did it make one's mind?
I think where it made the most difference was in the decision here of not to resume the here, where we found that the even though the ejection fraction improved, that the strain remained severely abnormal, and that influenced not resuming the trastuzumab and switching her to an alternative therapy. The other thing that I think it made a big difference is on here. Okay, here is the images where we're following her serially, and we're maintaining both a stable ejection fraction and a stable strain value. So that gave more confidence that we're giving her a drug that potentially is cardiotoxic, but that she's holding her own with the heart failure therapy that we're giving her. So you're correct. It's not that the strain in and of itself alone is going to make a difference. It's really the composite of the ejection fraction, the strain imaging, how well she's tolerating the medications, and also the balance of, do we have any alternative treatments? And given the fact that she has metastatic disease, our treatments are limited.
So, Nat, to answer your question, there's a big trial called the Sucker trial, which is nearly 2/3 of the way enrolling. That's looking at the role of strain versus EF in post-chemotherapy. Vera, can I ask you an audience question?
Sure.
Can you help them understand these curves? What do these lines mean, and what does a bullseye plot mean?
Sure. Okay, so the bullseye plots are shown similar to what we see in in our stress echo bullseye images or in our nuclear imaging bullseye images. So the little sections here on the outside represent the basal segments of the left ventricle. Here are the mid segments of the left ventricle, and here's the apical segments, and the middle here is the apical cap. And the numbers that you see here are the segmental strain values that are calculated for these specific segments. So here we see in this case that the strain values for the basal segments seem to be worse than the ones in the mid and the apex. And this is not amyloid, this is all chemotherapy mediated. These
Just
little strain...
clinical viewpoint, I never look at those lines. I like the polar map, and you have the numbers there also. So I don't go through all these different lines. I'm just telling you what I do in practice.
So you're talking about the curves, these curves. Yes. So these curves, each curve represents the strain in one segment. And these little dots here are the peak longitudinal strain values. And these little squares, these values are what are used to create this bullseye image.
Right.
So what these strain curves are most useful for is for you to see the quality of the image. Because if your curves are all over the place, that may suggest that that particular segment was not tracking well, and that the quality of your strain image may not be reliable. And if you have an unreliable image, then you can't really use that clinically. So I like to see the strain curves all lined up in this way here. And you don't have a particular curve that's bouncing off in nowhere's land that would suggest poor tracking of that segment. It also gives you a sense of timing, because again, these are all the peak longitudinal strain values. And if you see that there's a particular segment is reaching its peak at a different time, that may suggest desynchrony of that particular segment. So looking at timing, how well the curves lined up, and to make sure that there aren't curves that are just going the wrong way, to look at timing and to confirm the quality of your image. Oops, you're muted.
Vera, one last question, then we'll move on to Nat. What's the reproducibility of strain?
So first, we have to assume that the quality is good, because if the quality is poor, then the image is going to be very, very poorly reproducible. So assuring your quality, and the best quality is going to come from an echo image that starts out as good quality. So if you have a technically limited echo with poor endocardial border definition, then you're going to have a lot of trouble getting reproducible images. So assuming you have a good quality image and you get a good quality scan, the images should be reproducible. There is some variability between vendors, since vendors don't all use the same algorithm to calculate their strain. So if you're looking at serial studies, and it's very important for you to be sure that the values are exactly that the values are reproducible, then ideally you want to use the same machine for each patient. Now that has changed a lot over the years. I think the vendors are coming to the realization that reproducibility between studies or between vendors is important. So it has improved a lot over the recent past between vendors. But if you really want to be absolutely sure, then the best would be to use the same vendor for subsequent images in the same patient.
Thanks, Vera.
One question, final question, which Chandra also, I want Chandra's opinion also. You know, we did a study, and it's been published also, on patients with hypertrophic cardiomyopathy who had echo strain imaging as well as CMR. The premise before the study, I think what I was thinking and hoping was the areas with fibrosis on CMR would show abnormal strain in that particular region. But interestingly, that was not what we found. The abnormal strain correlated more with the thickness of the muscle rather than fibrosis. That was a kind of a disappointment to me. How do you explain that?
Right. So there are a number of different explanations, right? So the strain that you are looking is global longitudinal strain.
No, we looked at regional strain.
Yeah, which is predominantly affected by the subendocardial fibers, right? The longitudinally oriented fibers. A lot of fibrosis in hypertrophic cardiomyopathy is in the mid-myocardium. And so if you had done GCA, global circumferential strain or radial strain, you may have found.
Yes, we did. None of the regional strain correlated with the fibrosis. That was, again, I was hoping it would work out, but it did not.
So it's probably not as fine a technique to pick up that little amount of fibrosis.
Yeah, okay, I think that's what it is. It probably depends on the extent of fibrosis, the extent of the wall thickening, and I think there is still a lot of refinement that needs to be done on regional strain. So really looking at patterns and the global strain value is probably the most reliable at this point.
Okay, so Nat, let's move on to your talk.
Okay, let me get my slides. Share screen. Which one? This one. Share. Okay. I'm on. Chandra has charged me to talk about three-dimensional imaging in the clinical cardiology where we do. And I want to tell you that it's been a long journey, but at the moment we can really employ it on a regular basis. And it's the beautiful thing is you can just split open the heart, any region or any portion, and look at any given structure from many vantage points. Of course, you don't always get such beautiful pictures. This is from a transesophageal 3D. Transthoracic depends on the quality. If it's a good quality data, you can get some nice images. Otherwise, you can look at all these different structures so nicely as you see the anatomy here and the three-dimensional image here. That nicely is hard to see transthoracic. Younger people may be a little bit better. But fortunately now, most major companies, equipment companies, have equipment for three-dimensional imaging, transducers, processing and all that. And particularly whether you're employing a transesophageal probe. And that is a routine benefit and routine use almost every day in most major centers. Here is a collage just to tell you how nicely we can appreciate the anatomy. Here is one image. This is the left ventricle. We are looking at the mitral valve from below and just to see the opening. This is a reasonable opening, almost normal. On the right side here, we can see the mitral valve orifice is markedly reduced and severe mitral stenosis. And one can also quantify it using what is called a multiplanar method. Here is a transesophageal 3D. We are looking at an aortic valve sitting in the aorta, looking down on the valve. This is a bicuspid valve, and here is a raphe there. In this instance, we are looking at the interatrial septum from the right atrium. So this is SVC coming in, and this one is a large ASD. This is after closure. Here is a closure device, Amplots device that's shown. This is just to tell you that we can get beautiful images with a transesophageal 3D echo. Besides the anatomy and function, we can also do a three-dimensional color Doppler imaging. In this case, with a patient with mitral regurgitation, we can see the jet and more importantly, the site of origin of the jet. And that's important when planning valve surgery and so forth. So both for diagnostic purposes and guiding surgery or other procedures, there are certainly great benefit using 3D echo. And let's look at some more valve pathology. Take mitral stenosis. This is what I was telling you. Sometimes you want to get a short axis view or transverse view of the stenotic valve. And depending on the patient's imaging window, one may not always get it at the tips. Now, using a three-dimensional data set, we can make sure here is a tip of the leaflet that we get a transverse or short axis area for making measurements right at the location of the tip. Whether it's a transthoracic or transesophageal, it's the same. Here is a transesophageal image, another patient with mitral stenosis, and here is the 3D derived valve area from this data set. And you can see the image for qualitative purposes. This is the quantification of the valve area. And sometimes there are a lot of fibrosis and calcification. That kind of anatomy and the distribution of that also can be ascertained better. Here is another one showing a lot of calcium, and this is if the patient has severe mitral stenosis, this would not be a good patient for balloon valvuloplasty. Now, more frequently, patients undergoing mitral valve repair or surgery, one has to examine the mitral valve in kind of before taking the patient in planning the surgery. Just to give you an idea, this is an anatomic specimen, and this is a mitral valve we are looking from above, sitting in the left atrium. Generally, we divide the leaflets into, this is anterior mitral leaflet, this is posterior leaflet. We divide into different segments as A1, A2, and A3, and here P1, P2, and P3. And this is the information the surgeon would like to know. Here is a three-dimensional image showing you the same, the valve in a semi-open position. Now, Dr. Regulin will talk about mitral valve day after tomorrow, but just to tell you that whether the mechanism is degenerative or functional. And here is a degenerative mitral valve and with a flail portion here. On the other hand, this is a functional mitral regurgitation, either due to a dilated LV or dilated left atrium, where it pulls the mitral leaflets apart and they don't approximate and coagulate nicely. Let's go to a case. This is a patient who referred for surgery, and there is mitral regurgitation. Sometimes the TEE, the MR might be a little bit less, but this patient is symptomatic, needs to go on the surgery. We can go through many different two-dimensional views to identify which is a scallop, which is a segment that's prolapsing. The question is basically, which is flail, if we go, and we can kind of come to some kind of understanding. But when you do a three-dimensional imaging, it clearly shows nicely. You look at the anterior leaflet, posterior leaflet. This portion is a 1, that's flail, that's a P3 segment. So surgeon already knows, has an idea where he's going to put a neocard, whether there is rarely sometimes, so you need to do a resection. But most of the time nowadays, repair is done with neocards, and it works well. This is after repair in the operating room. This imaging is performed. After repair, there's no mitral regurgitation, and there's a ring there, but you can see the leaflet coapting nicely and closing nicely without any jet of mitral regurgitation. And let's look at another case. Again, it's a mitral valve case, and here are the two-dimensional 3D images, and you don't see the regurgitant jet in this cut, it's going underneath, and here is some portion is prolapsing, but then you do a 3D echo, and you immediately recognize here is an anterior leaflet, here is a posterior. You recognize it is this portion that is flail, okay, and here again, just in a little different vantage point, and you can see that's an A3, that's flail, and that is where the regurgitant jet also is starting from. Okay. The other areas are bulging, but the predominant problem is the A3 segment. Post-op, the same patient, and after repair, there's no regurgitation, and we can see that the valve is opening and closing properly. There is no significant gradient across the valve, so everybody is happy now. Now, how about this case? Here is a pre-op imaging, a lot of mitral regurgitation, and here is the appendage. So this portion is kind of flail, and then when you go to the short axis imaging, and you can see the regurgitant jet is in a kind of a medial portion, if you will. And then it is not a great 3D image, but it definitely points out the pathology. And after repair, okay, attempt was made to do the repair. Some residual mitral regurgitation. Little puff is okay, but this is not good enough. You don't want to take a patient to operate and bring the patient out with some residual regurgitation. So the patient went back and had some more attempt to do. This time what the surgeon looked at the problem and decided to put a little stitch here called Alfieri stitch to kind of connect the middle portions of the two leaflets, and after that there is no residual mitral regurgitation. And when we do clips, which we'll talk about on day 3, and one generally would create 2 orifices, and mitral valve clip is generally done with a 2D and 3D transesophageal echo guidance. You kind of alternate both, but 3D is extremely crucial. There are 2 clips here, and we got 3 holes across the mitral valve. So it varies depending upon how many clips one uses. Oftentimes, one ends up using 2 clips. So in terms of diagnosis and management, this is for valvular heart disease, it is critical, and so is the case in the aortic valve, but not as much as a mitral valve. For some patients who cannot have CT to look at the size of the aortic valve annulus, and one needs to know so that we can determine what size of the valve processes we are going to put in for TAVR. And in those circumstances, because of severe renal failure, they cannot have a CT, then the 3-dimensional imaging and getting the data of the aortic annulus is possible, and that's what we generally use in those few cases when we cannot do a CT. I'll probably finish with this case. Here is a 66-year-old man, 3 days of chest pain and dyspnea, and intense symptoms. He didn't right away come to the hospital, but as it was getting worse, and I came to the emergency room, tachypnea, tachycardia, and I will show you the EKG. Chest X-ray showed pulmonary congestion, and you can see the ST elevation in this anterior leads. So STEMI, this was just about 3 days ago, and immediately patient was taken to the cath lab, and you can see the lesions here, the multiple lesions, predominantly in the mid-LAD. Patient's right coronary also had lesions, but what was decided, just sent the culprit lesion here, so that was stented, and then only an echo was done. And then you do an echo, and here's imaging, transthoracic imaging. As you tilt towards the apex, you can see there is a defect in the septum, ventricular septal rupture. You can see the shunt. That explains why the patient is in heart failure. Here is a subcostal view, a little bit difficult, but again, the hole there in the septum can be seen, and the shunt. Now, that's an easy part. Then, as the study also showed, here is a kind of a long axis, short axis, some off axis view. There is a flow coming in. That was a systolic flow. Okay. Systolic and diastolic, predominantly systolic. Same thing in the short axis view, right there. Then one wonders, what's going on here? And here is also some suggestion. In addition to an infarct-related VSD, patient got a congenital VSD too, which is kind of can happen, but it's unusual. And then we did a 3D transesophageal echo, and that sorted out there is no membranous, perimembranous ventricular septal defect. This is just a normal flow going out the LV outflow, and there was no defect. And then all one had to do is this, fix the septal rupture. This is a 2-dimensional TE from the big, and here is a 3-dimensional image of the same defect. Usually, these VSDs are somewhat serpiginous. This, interestingly, is pretty circular, and here is a defect there, and it's about 2 centimeter by 2 centimeter, and the surgeon went in, found the hole, and put a patch, and then everything went well. Post repair, there's no much of a hole there. So in looking at valvular pathology or other anatomic abnormalities, 3D is fantastic, along with 2D echo. And then, as Veera was talking about, it's also 3-dimensional imaging helps you in determining LV volumes and ejection fraction, and also 3-dimensional speckle pattern is being normal. This is abnormal. This is a patient with ischemic disease with a scar in the apex, if you will. And the speckle tracking, 3-dimensional speckle is better than 2D speckle. Simply because 2D speckle, sometimes a portion of the myocardium moves away during the phases of the cardiac cycle. And other things that are evolving, what you call a fusion imaging. It could be CT and 3D echo, or it could be, here for example, here is a CT coronary angiogram, and this is the chamber derived from echo, and we have the strain data around that. And also, ultimately, I hope this will become a commonplace where we can make a 3D print of any given structure. Here I'm holding it in my hands. It's a pliable 3D printed solid model of mitral valve. And so more exciting things are coming. So right now, I could say transthoracic 3D echo is a little difficult to appreciate, to get the finer anatomy, but it's excellent for chamber quantification and strain imaging and so forth. 3-dimensional transesophageal echo is a standard in most of the patients with structural abnormalities, and also for guiding surgery and interventional procedures. We'll probably see some more cases, patient selection, device selection if you are doing interventions, intra-procedural guidance, efficacy of interventions, and also follow-up. So this is what we talked about, and that's all I have to say in these few minutes. Thank you, and love you all. Bye.
Thanks, Nat. We love you too. So
Love fest.
we are running slightly behind schedule, so let's go on to Ron's talk, and then we'll take questions in the end. Is that okay?
Sure, of course.